Really quickly, before we start chapter 25, I just want to kind of quickly just mention, sorry that I do not have the exam stuff up on Blackboard yet. I think because of the holiday over the weekend that the testing center is just working a little bit slower. I am going to change a couple of the answers, and so I submitted that to them, and I'm just waiting to get the final grades back before I post those. So I do apologize for the delay. I am hoping that they will certainly be up. Both my note and the grades will be up later this afternoon by the end of the day today. Again, I have changed a couple of the answers, so your grade may look a little bit different this afternoon when you see it in Blackboard than it did right after the exam. And I'll, as always, provide my rationale and my note regarding those changes. So just wanted to quickly mention that, let you know that it is a little bit more of a delay than I like or that I usually try to have in terms of getting you your feedback, but just a little bit of a delay because of the holiday, I think. So I apologize and thanks for your patience. All right, so let's get started with chapter 25. Again, structure and function of the pulmonary system. I think as I mentioned with the cardiovascular system discussion that we discussed last semester, I talked a lot about how I feel like it's probably one of the systems that I really want to drive home the hardest to you in terms of clinical relevance and just kind of making sure that you truly have a good grasp on it. I would echo that with pulmonary. Especially if you're interested in ICU, critical care aspects of nursing, it's going to be something that you deal with on a day in and day out basis. So again, today is sort of that groundwork, trying to sort of give you that good sort of foundation in terms of structure and function, so that as we talk more about alterations in the days ahead, that you sort of have a good grasp and good foundation for that. So again, very relevant to clinical and to our practice, and structure and function. You got to start with that. So objectives for you. All right. So very quickly, we'll discuss structure. Obviously, we have two lungs and airways that accompany that, the bronchi. We do have lobes, so certain compartments of the lungs. We've got 3 lobes on the right and 2 on the left. We've talked, especially already in terms of the cardiovascular content, we've talked ad nauseum regarding the pulmonary circulation, right? We know that blood moves from the right to the left side of the heart through the lungs. So we know that there is a very intimate relationship between the cardiovascular system and the pulmonary system. In discussion of chest wall, we really are looking at sort of the whole thoracic cavity. And what I mean by thoracic cavity is obviously the skin that surrounds that. The ribs will certainly be part of that thoracic cavity. All of the intercostal muscles in between those ribs. And the reason that I talk about that is because there has to be a good closed sort of circuit, good closed connection between all of those structures within the chest wall, within that thoracic cavity for effective mechanical movement for breathing, for effective perfusion of gas into the circulation there in that chest. So when we talk about like chest wall injuries and things like that, steering wheel to the chest kind of things, we're talking about perhaps a major alteration in that ability of both mechanical but also sort of the function of what lies in that chest wall. And we'll talk, again, more about those alterations in the days ahead. In terms of the pleural membrane around the lungs, there is indeed a sort of pleural double membrane that encases the lungs, just very similar to the what? Pericardial membranes, right? It's a, 2-layer membrane that sort of encloses the lungs. Again, what is the function of that? What is the purpose of this 2-layer membrane? So we have the parietal layer that is more of the outside lining, and then the visceral layer that's more on the internal side of that layer, and there's a space in between those layers. What's the purpose of that? What is the true sort of function of that bilayer, so to speak? Decrease friction. And again, very, very important in terms of, the pulmonary health, because there's obviously a lot of movement in the lungs and in that chest cavity in general. So we want to be able to allow those layers to slide over each other nicely without separating, decreasing friction, so therefore obviously decreasing pain and discomfort when the lungs are moving, and also allow for proper expansion to allow for gas exchange. Very good. So that serous membrane does adhere pretty firmly to the lungs, like that pericardial sac, but there is that space in between that allows for decreased friction. Good. Very, very good. And then last but not least on this slide is the mediastinum. We've talked about this a little bit already. Remember, that is that space between the lungs that really sort of encases the structures like the heart, the great vessels that come out of the heart, and then a little bit of the esophagus. So when you're talking about the mediastinum, you're talking about a little bit of the GI system in that area as well. So again, real quick little review of the structures, but wanted to mention it as we move forward today. So when looking at this picture of the thoracic cavity, again, the thoracic cavity is divided into sort of 3 subdivisions because of those pleural divisions. So the pleural sac, or the pleural membrane, kind of divides up into the right lung, and you can see here these sort of divisions, the left lung, and then again sort of the mediastinum right here. And again, all of them are sort of partitioned off and formed by that serous membrane of the pleura. So I wanted to kind of provide you a visual here as we move forward. Okay. So in continuing our discussion regarding structures of the pulmonary system, we're going to start with the structural side. Okay, so we're going to sort of start with the structural side of things as we start this morning, and then we're going to move kind of forward later on this morning and talking more about sort of the functional mechanical side of things of the pulmonary system. So when talking about the structural side of things first, we kind of divide the structure of the pulmonary system into sort of 2 categories. Conducting airways, or the conducting system, and then sort of the gas exchange system. So we'll start here first with discussing the conducting airways. When I'm talking about the conducting airways, I'm talking about the parts of the pulmonary system, or the airways, that allow air into and out of the gas exchanging structures. So when I'm talking about the conducting airways, I'm not talking about the parts of the pulmonary system that actually partake in the gas exchange. I'm talking about it just allowing for the gas to get to the areas of the pulmonary system that actually exchange gas. So those things that don't really exchange gas but just conduct the gas are the kind of divided up into upper and lower airways. So the upper airways would be like the nasopharynx, so sort of in the back of the nose, oropharynx in the back of the mouth. The larynx kind of connects the upper and the lower airways, and also houses what? What else is sort of in the larynx area? What's that? Vocal cords. Very good. The voice box. Good. So you've got your upper airways, your larynx, and then the lower airways consist of the trachea, the bronchi as they sort of branch off into the right and left. And then at the end of those bronchi are sort of, it gets even smaller in what we call the terminal bronchioles. Now, the terminal bronchioles is sort of the formal end, if you will, of the non-gas exchange structures. So once you get anywhere farther down below those terminal bronchioles, we're talking about structures of the pulmonary system that actually that actually exchange the gas. Okay? So really this slide here are all of the airways that just help gas get to the lower parts of the pulmonary system. To be clear, none of these structures on the screen here actually do any conduction. I keep saying conduction, I don't mean to confuse you. Any exchange of the gas. So to be clear, no gas exchange occurs in any of these structures that we're talking about. They only conduct the gas to those structures. Okay? So that being said, here is a really good sort of picture of what I just said. I've kind of divided up here between conducting airways and then the actual respiratory unit, or the gas exchange structures. Yes, bless you. So if you were to draw sort of an imaginary line right here, that's where you would sort of make the division between all the structures that don't exchange gas and all the structures that do exchange gas. You draw the line right here. Okay? To be clear. We'll come back to this. Okay, so then let's talk a little bit about the areas that do actually exchange the gas. So anywhere below those terminal bronchioles, now you've got it branching even more into the respiratory bronchioles, and now we're talking about in each lung this is occurring. So you've got the respiratory bronchioles. From the respiratory bronchioles, you get even farther branch and even deeper into the alveolar ducts. And then each one of those alveolar ducts sort of ends with an alveoli. Now, what is the alveoli? talking back, thinking back to your A and P, what are the alveoli in the lungs? They're the sacs. They're where the gas exchange, most of the gas exchange occurs. If you were to sort of, again, very sort of fundamentally and not very sophisticatedly, draw a picture on the board here, you can think about it in terms of at the end of each one of these respiratory bronchioles and the end of each one of these alveolar ducts, you literally have just like these little sacs, right? At the end of each one of those airways. Now, those sacs, those alveoli, are made up of epithelial cells, and there's a couple of different types of alveolar cells that you'll find there. One, you have the type 1 alveolar cells that really just truly provide sort of the alveolar structure, so they actually kind of just make up the walls of those sacs. And then you have the type 2 alveolar cells, which actually secrete surfactant. Now, what is the purpose, or what is the overall sort of goal of surfactant? Anyone remember about that from A and P? Yeah. Right, to keep, and even more specifically, keep each alveolar sac, each alveoli expanded. How does that work? How does the surfactant do that? Anyone remember? Right, it actually decreases surface tension inside each one of those alveoli. Right, and the reason for that is that surfactant is actually like a lipoprotein that coats the inner surface of each one of these alveoli. So it coats the inner surface of each one of these sacs. And because it's there, it lowers surface tension at the end of expiration every single time. After every single expiration, it lowers the surface tension inside those spheres, inside those sacs. Especially when you're talking about a sac or some sort of sphere that has basically water on the inside of it. Every time a sphere gets smaller, so as you're exhaling in that alveolar sac, the radius of that sac decreases, and as that sac gets smaller, what happens when there's water on the inside of that sac? Those water molecules want to stick together, right? And it would be extremely hard to sort of reinflate that sac, reinflate that sphere. Thank you for the sound effects. I'm just teasing you. If you were going to do it, I was going to do it. So as the radius gets smaller and smaller, and there's water on the inside of that, those water molecules want to stick together. And so if you were going to try to then re-expand that sac by taking in another deep breath, it would be very hard to sort of reinflate that sphere if it wasn't for surfactant, because surfactant sort of acts like a lubricant on the inside of there, an actual lipid sort of protein that actually allows for those to slide over each other and reinflate. And we're going to talk more about that specifically in just a little bit. So in order for proper lung expansion to occur, we need surfactant. That's why we're so worried about those preemies, those premature babies that are born like less than 28 weeks gestation, because those type 2 alveolar cells have not secreted surfactant yet. And so we're really concerned about those little preemie less than 28-week gestation babies and their respiratory health, because re-expanding every alveoli after every expiration is very difficult for those babies. And we're talking about major sort of respiratory distress. We'll come back to that in just a little bit. But again, that is sort of the makeup of the alveoli. Now, all three of these structures, the respiratory bronchioles, the alveolar ducts, the alveoli themselves, participate in gas exchange. Anyone know why they're so good and they're sort of so good at and sort of predisposed for adequate gas exchange? I'm sorry? Yes, they're coated and just sort of create this wonderful relationship between the alveoli and the capillaries, because they're just kind of intertwined around every single alveoli. Right. And beyond that, why does that work? Anyone know? Why is there such good communication and good relationship between the capillaries that surrounds each one of these structures? Mm-hmm. It does. It does allow for really, every sort of sac is covered very well with a really nice, good sort of network of capillaries. Yeah? Right. The walls themselves are so thin because of that unilayer of epithelial cells, that all of these structures are so thinly walled that it allows for really good communication and really good sort of diffusion of that gas across that line from the alveoli to the capillaries. And we're going to talk more about that more specifically in just a second too, but that's perfect. Very good. And here's sort of a good illustration of that. So as I just mentioned, you have each one of your alveolar ducts that sort of end in one of these alveolar sacs, right? And look how beautifully covered each one of these alveolar sacs are by this wonderful network of capillaries, right? And you have to have a very thin wall between that alveoli and that capillary to allow for proper diffusion of gas to occur, right? So all the gas exchange occurs here between the respiratory and the cardiovascular system through these, networks of arterial and venous capillaries. Perfect. And here's even a tighter picture of how much blood supply is in and around every single alveolar sac. And again, we're going to talk more about that in just a second. But before we do that, really quickly, you really can't talk about the pulmonary system structure without talking a little bit about the defense mechanisms that sort of supports and protects our pulmonary system. And again, probably, a lot of these are very familiar to you. I'm sorry that it's so tiny. But I just wanted to do a really quick review on this slide before we move a little bit deeper into the structure. Okay, so upper respiratory tract mucosa. We know that it's the upper respiratory tract mucosa that really maintains that constant temperature and humidifies a lot of the air and the gas that's coming in to our pulmonary system. It also works at sort of trapping and removing a lot of those foreign particles. The other one I just want to sort of bring your attention to are the little nasal hairs and turbinates within the nose. And the nasopharynx, again, good for trapping and removing a lot of those foreign particles. And then the mucus blanket protects a little bit farther down, so it protects our trachea and our bronchi from injury because it is, mucus. It's sort of sticky and it sort of helps to trap and prevent most foreign particles from getting down into our lungs and from reaching even the lower airways at all. And anyone know what epithelial cells actually sort of epithelial cells of the bronchi that actually secrete that mucus? Anybody remember that from A&P? Goblet cells? Does that ring a bell at all? It's the goblet cells that actually help create that mucus blanket. And then last but not least, you have the cilia, too, that actually help mechanically propel that mucus blanket and mechanically trap the particles and actually kind of get them back up to sort of be able to either expectorate, or sometimes we actually end up sort of swallowing that as well through our GI system. But those are the parts of the sort of pulmonary defense mechanisms that I just wanted to kind of remind you of. Again, can't really talk about the structure without talking about the sort of the protection of that structure. Okay. All right, so any questions regarding structure to this point? We're going to move a little bit more forward and talk more about the structure of this relationship between the pulmonary and the sort of cardiovascular side of things. But any questions before we move forward into that? Okay, all right, good. So what I want to say first, before we really even get into this slide, is that the pulmonary circulation facilitates, and we know this, right? But the pulmonary circulation facilitates gas exchange. It facilitates the delivery of nutrients to the lung tissues. We know that the pulmonary circulation acts as a blood reservoir for the left ventricle. I mean, we know that, right? If there's any sort of backup in the left ventricle, the blood's going to back up into the lungs. So we know that it kind of acts as a blood reservoir for the left ventricle. It also filters and can sort of remove any sort of small little clots that may be in that circulation. Any air or other debris that may be in that blood, the pulmonary circulation can kind of filter that out as well. So just kind of keeping that in mind, when we're talking about the structure of the pulmonary system and of those bronchioles more specifically, you really have to discuss the circulation in and around those structures as well. So we know, right, we've already talked about this when we talked about the cardiovascular system, that the pulmonary circulation has a much lower pressure in it than the overall sort of systemic circulation. And when I say that, to be clear, the pulmonary arteries are exposed to sort of a fifth of the pressure that the systemic circulation is exposed to. So it's a very much, to be clear, a very much lower pressure system than our overall sort of systemic circulation is. And then, this slide has a couple of other sort of informational sort of things on there. But what I really want you to understand is that the pulmonary circulation has a much lower pressure than the systemic circulation. And then at the end, the other thing I really want you to understand is that each bronchus and each bronchiole has an accompanying circulation to it, right? It has an accompanying artery or even smaller an arteriole. And if you go back 2 slides again, this really illustrates that. Within each sort of pulmonary structure, you've got a very defined, very important sort of circulatory or cardiovascular structure associated with each one of those bronchioles and alveolar sacs. And this sort of shows you that exactly, how each one has an arterial, both arterial and a venial, that then has a very good sort of capillary network at each one of those. Now, I am harping on that so much. Okay, why? Let's talk about it. The reason I'm harping on that exact sort of concept is because of this right here at the top of the screen, the alveolar capillary membrane. This is exactly that sort of relationship, that area of communication between the alveoli and each capillary that it sort of feeds. So formed by the shared alveolar and capillary wall. If you don't remember anything else, what I want you to understand is that in this exact spot, this spot where the capillaries are right up against that alveolar wall, is where gas exchange occurs. So a gas exchange occurs across this membrane through diffusion. Okay? I definitely want you to understand that. The capillaries enclose and wrap around each alveoli, and that's where adequate gas exchange occurs, where those 2 structures meet at that membrane. Okay? Now, there also are pulmonary veins surrounding each one of those alveolar as well that drain the pulmonary capillaries. They're certainly, running very sort of intricately throughout the lungs as well. And then that's where the pulmonary veins actually leave the lung and enter the left atrium to take that good oxygenated blood to the left atrium to get pumped up and out to the rest of the body. But again, it's this alveolar capillary membrane where all of the important gas exchange occurs. Now, here's a great picture of that, right? So if you sort of note that this is sort of a cross section, I've sort of cut an alveoli in half and cut the capillary right there. It's in this box, right, that all the gas that comes into this alveolar sac gets diffused across this nice little thin membrane right into the bloodstream, right? And then vice versa. The blood that's carrying all of the waste product, the carbon dioxide, back to the lungs, the carbon dioxide goes from the blood into the alveolar sac to get expelled out, right? So you're having oxygen move through this thin membrane into the blood, and you're having carbon dioxide move from the blood into the alveolar sac to get exhaled. Now, what's important to note about this relationship that you find here in this box is that the thickness of that wall between the respiratory component and the cardiovascular component, the alveolar sac and the capillary, it's the thickness of those alveolar capillary membranes that influences the diffusion of that alveolar gas, right? So why do I say that? Why do I dwell on that so much? What factors could inhibit the thickness of that wall and therefore inhibit the adequate diffusion of those gases? Clinically speaking, what are we talking about? Yeah. Okay, inflammation, very good. Any sort of thickening or inflamed condition to this membrane here would certainly impact the ability of these gases to diffuse in the proper directions. Good. Scarring, any lung scarring in those particular alveolar sacs would certainly cause a thickening to that wall and allow for improper diffusion. Good. So really you can think about it in sort of the respect of a thickening or even kind of like a separation, right, of these walls from touching each other to allow for that proper diffusion. So in sort of addition to what has already been said, I would include things like fluid If there's any sort of fluid present in this area of this relationship, gas does not go through fluid well, right? So if there's a fluid buildup in these alveolar sacs, maybe like because of CHF, right? There's a backup and there's increased fluid in each one of those alveolar sacs. You're going to have inadequate diffusion of the gas. How about if someone's got pneumonia and they've got actually like exudate, like infective sort of exudate built up in each one of those alveolar sacs? That's going to not allow for proper diffusion of gas along that wall. How about a clot? You know, if there's a clot sitting right here in this capillary, again, gas doesn't diffuse very well through a big honking clot sitting there, right? That's not going to allow for adequate exchange of gas. Mucus, you know, all of those types of things. So really, just in your mind's eye, imagine anything that could sort of lay right here and block any of that diffusion of gas from one structure to the other. Again, oxygen cannot diffuse across long distances, and it cannot diffuse against sort of, you know, these big sort of roadblocks in the way. So gas exchange depends on a very close relationship between that capillary and that alveoli. And I hope clinically that makes sense to you in terms of clinical relevance of why we care so much about the health and sort of the adequacy of that alveolar capillary membrane. Okay. Any questions about that? Because you really have to be clear about this before we then continue to sort of move forward and talk more about gas exchange in the lungs. Okay. All right. So we're kind of putting structure aside now, because if you understand the structure, now we can talk more specifically regarding the function of those structures. So when talking about the function of the pulmonary system, we have to talk about ventilation and perfusion. Now, have you heard those terms? And are you crystal clear about what each one of those terms is and the difference between the two? No? Okay, good, because we're going to talk about it. So, when we're talking about the function of the pulmonary system, we're talking about ventilation and perfusion. So this is how I want you to remember it. You have to ventilate the alveoli first. And so whenever I say ventilate, am I talking about, these markers. Oh, that's even worse. Let's try that one. Thank you. When I'm talking about ventilating the alveoli, I am talking about getting gas to the alveoli, getting oxygen, right? So when you hear ventilate, think gas. You have to ventilate the alveoli first. You have to get gas, oxygen into each one of those sacs in the lung tissue, right? Then you diffuse that gas into and out of the blood through that alveolar capillary membrane that we just talked about ad nauseum, right? Then once that gas gets diffused into the blood, we're talking about perfusing. We're talking about perfusion. So you perfuse the lungs so that the organs and tissues of the body receive that oxygen-rich blood. Okay? So when you're thinking about perfusion, we're talking about blood. More specifically, oxygen-rich blood, right? So have you ever heard in clinical, or do a little dance up here, have you ever heard in clinical anyone say sort of like, oh, he's not perfusing well? Or, those types of sort of conversations. When you hear like, oh, he's not perfusing well, that means that there is a problem with getting that oxygen-rich blood to the tissues of the body. What would someone look like if they're not perfusing well? Right, you'd have issues with cyanosis. If they're not perfusing their kidneys well, we're talking about, decreased urine output, things like that. So ventilation means gas, means actually getting gas to the alveoli. Perfusion means getting that oxygen-rich blood out to the system. Does the difference make sense? Is that clear to you? Yeah. Perfect. And we're going to talk about that at the end of the day today, that you can have a ventilation-perfusion mismatch, where perhaps you're ventilating well. Perhaps you're getting the oxygen into those alveoli, but there's an issue with getting that oxygen into the blood, and then you have a perfusion problem, or vice versa. You know, maybe you've got adequate blood supply, blood's flowing, but you've got some sort of blockage so that gas isn't getting into the alveoli. So it's very possible to have a ventilation-perfusion mismatch, and we're going to talk about that at the end of the day today. So that's perfect. You're already sort of thinking ahead. Yeah? Yeah. Yeah. I mean, you're going to have an issue if there's any kind of mismatch, right? If you've got blood but no oxygen in that blood, or if you've got perfect amount of oxygen but you can't get that into the blood. Either way, you're going to see issues with cyanosis. Right, very good. And that'll hopefully become a little bit more clear to you when we start talking about the mismatches clinically at the end of the day today. Good, very good questions. Excellent. So again, you've got to have both. You've got to have both ventilation of those alveoli and perfusion to be able to allow for proper functioning of tissues in the body. Very good. Now, as you see here on the screen, it also says that the body can receive blood that is rich in oxygen and low in carbon dioxide, right? So you have to have that adequate exchange in the alveolar capillary sort of membrane of oxygen into the blood and then getting that CO2 out of the blood and into the alveolar sacs to be able to blow off and exhale out. Very good. Any questions about that? Is that clear now? What I want you to understand from this slide is the true definition between ventilate and perfuse. Is that clear to you? Nod your head if that's true. Okay. Want to make sure we're together on this. Okay. So in continuing our discussion regarding function of the pulmonary system, let's talk a little bit about, more specifically about ventilation, to ventilate. Okay? So you can also sort of use that interchangeably with respirate, with respirations, right? So ventilation in our patients is respirations, right? And so that being said, it's the mechanical movement of gas into and out of the lungs along a pressure gradient in the lungs. And it's responsible basically for our lung sounds. So when you're doing your physical assessment and you're auscultating someone's chest for lung sounds, you are listening to their ventilation. You are listening to that mechanical movement of gas into and out of the lung fields, right? And when talking about how quickly someone is getting that done, we're talking about their respiratory rate, right? So that is actually the ventilatory rate. It's how quickly they're ventilating. So really, i.e., the number of times the gas is inspired and expired per minute. So if you were to sort of think about the cardiovascular system, what would be sort of the synonymous sort of thing to a respiratory rate when talking about the cardiovascular system? The heart rate, right? So the respiratory rate is sort of the same thing, sort of a synonym, really, for like the heart rate in the cardiovascular system. It's the number of times that the gas is per minute. So tidal volume, then, is the volume or the amount of air per each one of those ventilations, right? It's the volume or the amount of air per breath. So again, if you were to sort of compare that to the cardiovascular system, what would that be? Not cardiac output. Stroke volume. Thank you. I'm just going to stand here and wait long enough till you say the right one, right? That would be the same sort of thing as stroke volume, right? It's the volume. It's the amount of air that's being sort of taken in and pushed out every time there's a breath, right? So that's tidal volume. Okay, so respiratory rate is the number of times someone inspires and expires. The tidal volume is the amount of air that someone inspires and expires. Do those two definitions make sense to you? Yes? Yes? Okay. Now, to take it one step further, now the next thing you need to discuss is this minute volume, right? So this is the ventilatory rate or the respiratory rate times the tidal volume. That's your minute volume. So it's really telling you the amount of sort of intake and output, so to speak, of the lungs of that gas. So now, in terms of the cardiovascular system, what is this synonymous to? Cardiac output. Good. Because this is ventilatory rate or respiratory rate times tidal volume. So this would be your minute volume, or like in, comparison to the heart, your cardiac output. Okay, so that's how you figure out these things. That's how you figure out the minute volume, is through like a calculation, right? Respiratory rate times tidal volume. But the other thing that you really need to be thinking of, maybe even more importantly or more specifically, is alveolar ventilation. So it's great to know what someone's respiratory rate is. It's great to know how fast they're breathing. It's great to know the volume of air being taken in each time they're breathing. But what is the actual ventilation of the alveolar sacs? How much oxygen are they actually getting in? There's really not a calculation. There really is not a sort of an equation for finding out alveolar ventilation. Anyone want to take a stab at how we actually know clinically how well someone's ventilating each one of their little alveolar sacs? Say it louder, I hear murmurs. SpO2? SpO2 to a lesser degree, but so that's like, your pulse ox. What would be even more specific than that? Actually looking at the oxygen pressure in their arterial blood. So doing an ABG, an arterial blood gas. Actually looking at the partial pressure of oxygen in someone's arterial blood. Right. So again, cannot be determined by just, knowing these things, knowing this calculation, but really have to look at the PO2, the partial pressure of oxygen in the blood, in the plasma. Good. And you do that by doing an ABG, actually doing a blood draw from the arteries. Yeah?
If the little alveolar sacs weren't getting as much, wouldn't they kind of shrivel up?
It depends on the reason for why. Yes, if there's a blockage there, like because of mucus or something like that, yes, they would start to shrivel up, and we'll talk more about that later at the end of the day. But yes, they would. Yeah, but we really want to know how well they are ventilating, and the only way to truly know that is by looking at the partial pressure of oxygen present in the plasma. Very good. Also, another thing that you can really find out from an ABG is the partial pressure of carbon dioxide. And during ventilation, we know, right, that during proper ventilation, not only are we supposed to be getting oxygen in, we're also supposed to be getting carbon dioxide out, right? So during ventilation, CO2 is supposed to be eliminated to maintain a normal sort of arterial CO2 amount, but also a normal pH, right? We know that when CO2 builds up, it can make someone very acidotic and change their pH, right? So that can also, the alveolar ventilation can also tell us about the CO2 content as well. Not only do we need to have adequate O2 coming in, we also need adequate CO2 going out. And we'll talk about the sort of the numbers of this on Thursday, but just so you sort of are aware, what we would want to see in sort of arterial blood is that the CO2, what am I doing? 40. We would want the CO2 level to be about 40 in arterial blood, 40 millimeters of mercury. And we'd want oxygen to be pretty close to 100. Okay? That's how, it's these numbers right here that would tell us that there's adequate alveolar ventilation occurring. And we're going to talk more about partial pressures of gas in the blood on Thursday. But I wanted to just mention that. Okay? What would be some diseases? So let's kind of try to put this clinically relevant. What would be some diseases that may limit ventilation, that would sort of result in a decreased ability to sort of get that CO2 out, and then therefore you'd see CO2 build up, or you'd see CO2 start climbing above 40 millimeters of mercury? What would be some clinically relevant sort of conditions that might lead to CO2 sort of buildup? What do you think? COPD, that constrictive, restrictive kind of lung disease that it does not allow for proper ventilation and proper exhalation of that CO2 out. So perfect. COPD, I would also add to that like an opioid overdose where they're just hypoventilating, they're just not really blowing all that CO2 off effectively. I would also add maybe any type of neurologic disorder in which there is diaphragm weakness. And again, they're just not strong enough. The muscles, their respiratory muscles are just not strong enough to properly ventilate and blow that CO2 off. So I would say anything neurologically like ALS that would cause diaphragmatic weakness. COPD, as you guys mentioned, an opioid overdose, they just kind of have sort of overall hypoventilation. All of those things would cause a buildup of CO2 and then therefore an increase in this number above 40. Yeah. Depending on, it's not so much what's actually in their lungs. like a tumor or fluid or something like that. It's more talking about the ability of the lungs to sort of expand and contract and push that out. So it's not so much what's in the lungs, it's almost like how elastic they are. Yeah, or how elastic those muscles are around it to help with that. Yeah, good. Good questions. Way to be sort of thinking clinically. Good. Okay, so again, we're going to come back more to this discussion of sort of partial pressures of those gases in the arterial blood, but I wanted to just sort of mention this to you today. Does that make sense? Is that clear? Yes? Okay. Great. Okay. Now, what controls ventilation? There are actually two different types of receptors in our bodies that control that process that we just talked about, that ability to sort of expand and contract our lungs and push air in and out. And a lot of it has to do with neurochemical control. So these receptors that we're talking about are neurochemical receptors. So first of all, ventilation, to be clear, does not require our conscious effort, right? We're all sitting here in this room, sitting at these tables, sitting in these chairs, just breathing without thinking about it. Okay, so now that I've mentioned it, you guys are all thinking about it. So now you're like, right? But under normal circumstances, when I do not bring your attention to it, it does not require conscious effort. Is that true? Would you agree with that? Right. And because of that's sort of because breathing is controlled by upper motor neurons located in our brainstem and in our medulla. And we know that because we talked about that already when we talked about our neurocontent, right? And we referred to that brainstem medulla neurologic control of our breathing as our respiratory center in the brain, right? Now, it's this respiratory centers in our brain that kind of control these two different receptors that I've mentioned, the central receptors, and then we have on the next slide peripheral receptors. So let's talk a little bit about the first sort of central receptors. So these are our respiratory neurons, referred to as central receptors, that are particularly sensitive to chemical changes in our cerebral spinal fluid that sort of bathes them, that sort of runs in and around these receptors. So where is cerebral spinal fluid found? In the brain and in the spinal cord, right? We know that from our neurocontent. So that's where you're going to find these central receptors of ventilation, is in our brain and in our spinal cord, okay? Now, to be clear, with these central receptors are stimulated by high partial pressures of CO2. So above this 40 millimeters of mercury. What do you think these central receptors are going to be stimulated to do if the partial pressure of CO2 is high? Breathe. Exhale, right? Get that CO2 off, right? So they will be stimulated if partial pressure of carbon dioxide is high, and then there's a low pH, right? If you see high CO2, the pH is going to be low. The person's going to be acidotic, right? So they're going to be stimulated to take a deep breath in and push that CO2 out if the PCO2 is high and the pH is low. They will be depressed. They will not be stimulated if the PCO2 is low and the pH is high, right? So again, what this is basically telling you is that central receptors are dictated by CO2 levels. Okay? They are controlled by CO2 levels. They will either be stimulated to breathe or they will be depressed. Say, no, we don't need you to take a deep breath right now, depending on if the PCO2 is high or low. Does that make sense? Okay. Now, the issue, so again, to be clear, central receptors are dictated by CO2. Now, the problem lies in that if you've got some sort of clinical condition where the person has sustained hypercarbia, and hypercarbia means high CO2, you'll hear hypercapnia, hypercarbia, all that means elevated CO2. If you've got a clinical condition in which there is sustained or sort of chronic hypercarbia, this dulls the responsiveness of these central receptors to any further increase in CO2. So it's almost like the boy who cried wolf. If you've got someone who is living every day with a really high CO2, eventually your central receptors are going to get like, okay, yeah, I'm tired of you always telling me that the CO2 is high, and they're going to quit. They're going to quit working. They're not going to be as responsive to CO2 levels anymore. Again, so I kind of think about it as like the boy who cried wolf, right? Like, yeah, we've heard you already. You're high CO2. And they stop paying attention, right? That's the problem with central receptors, is that if you've got chronic hypercarbia, it dulls the responsiveness of those central receptors. Luckily, we've got some peripheral receptors. Now, these are arterial chemoreceptors located in the aorta and located in the carotid bodies, actually in the carotid arteries, okay? They're also sensitive to chemical changes, as were the central receptors, but these receptors are very sensitive to chemical changes in the blood surrounding oxygen levels, okay? So peripheral receptors are different than central receptors in that they pay attention to oxygen levels. Okay? So, it's a less, low oxygen is a less potent respiratory stimulus than like the CO2 and with the central receptors, but it definitely is still there. It's definitely still present as one of the reasons that sort of drives our ventilation. Okay? Now, obviously, it'd be sort of less of a good stimulus in places where there's sort of, always low oxygen, like in high altitudes and things like that, but it still is very effective. So again, central receptors pay attention to carbon dioxide levels, peripheral receptors pay attention to oxygen levels. Now, going back to this person who lives in this chronic high CO2, chronic hypercapnic state. So first of all, what kind of individual would that be, that they're sort of chronically have high CO2 levels? COPD, perfect. Hypoxia becomes a very important respiratory stimulus in these people who are chronically hypercarbic. Because again, their central receptors have turned off. They are so tired of hearing about your high CO2. They've turned off. So really the only drive for these chronically hypercarbic people to breathe is hypoxia. They only pay attention to low oxygen to sort of drive them to breathe. So let's say clinically you've got a COPD patient coming in. Let's say they're coming into the ED. They're in sort of an acute sort of crisis. You slap pulse ox on them and their oxygen's 86. You think you're going to do the right thing by helping this hypoxic patient. You slap on a non-rebreather, crank up that oxygen to 12 liters. What have you just done? You've taken away their drive to breathe because they are no longer controlled by high CO2 levels. They're only controlled by hypoxia. Now you've just made them not hypoxic by giving them all this oxygen, and you're going to turn off all of their drives to breathe. Does that make sense? That's why we are very, very vigilant in patients with like COPD, and that you don't give them high levels, high volumes of oxygen, because they need that underlying hypoxic state to help them drive to breathe. Because if you bring their oxygen up to a beautiful, 99%, you've now taken away that hypoxic drive to breathe, and they may go into respiratory arrest. Again, has to do with this relationship between central receptors and peripheral receptors in terms of who's motivating who to breathe. Yeah?
So people with COPD, like clinically, how do you determine whether they're at a therapeutic level?
Yeah. You have to look, so you can still give them a little bit of oxygen, but do it very, very sort of judiciously, especially when you're first starting out. Give them, 2 to 4 liters per nasal cannula. See how they look. Are they working really hard to breathe? Are they still super short of breath? Are they able to sit there in the stretcher or the bed and talk to you and have a full sentence? So look at it more clinically of how they're doing. If they're still really short of breath and they're still really working hard, you may need to think about, doing sort of other kind of interventions, like getting respiratory therapy on board and maybe doing more of like a CPAP sort of situation where you're blowing off some of that excess CO2 and focusing more on the CO2 and less on their oxygen levels. Good question. Yeah, very good question. But again, it's not that you say you can't give them oxygen at all, but you should be very, very judicious, especially in the beginning. Good. So again, these respiratory neurons can be depressed by low serum PCO2, but also things like narcotics, sedatives, hypnotics, anesthesia. So we're talking about someone going under, general anesthesia for surgery. All of these things can dictate their neurochemical control through their central receptors and their peripheral receptors in terms of CO2 and oxygen levels. Okay. So again, we are just as concerned with someone's capnography, so looking at their CO2 levels, as we are with their oxygen, right? Because they can be really well oxygenated. Their O2 can look pretty good in terms of their stats on the monitor, but they could still be retaining CO2. So we're adequately concerned, or adequately, I should say, we are equally concerned about their CO2 level as we are their oxygen level because of these receptors. Does that make sense? Okay. So we're going to very closely monitor both. All right. So when talking about ventilation, we also have to talk about the actual mechanics of breathing, right? We actually have to talk about sort of the very sort of fundamental ability of someone or our patients to get gas into and out of our lungs, right? And we're talking about mechanics of breathing when we're talking about that. And there are really, let's see, 1, 2, 3, 4, 5 factors that you're thinking about that you have to sort of consider when talking about mechanics of breathing. So let's do that. First things first. Number 1, movement of air or gas from higher pressure to lower pressure is how we breathe. And again, this may not seem perfectly intuitive, so let's kind of do this as a group, okay? So think about this. When you inhale, you actually lower the intrathoracic pressure inside your thorax, inside your chest cavity, below atmospheric pressure. And the reason for that is that when you inhale, the diaphragm contracts and draws downward, okay? So again, that's kind of the opposite of what you think. You think when the diaphragm contracts that it kind of goes up. It doesn't. When you think about contracting the diaphragm, when you take a nice, big, deep inhale in, your diaphragm draws downward, which increases the volume within the thoracic cavity. When you increase the volume inside the thoracic cavity, you create a negative pressure inside the cavity. So the pressure inside your chest is less than the atmospheric pressure out here. What does gas want to do? It wants to go from high pressure to low pressure, and it just kind of gets sucked in, negative pressure, into this increased volume in your thoracic cavity, right? So when the diaphragm contracts, it draws downward, which increases the volume of your thoracic cavity, creating a negative pressure that draws gas into the lungs. It's what we do. It's the natural, physiological way that we breathe. Now, why do I harp on that? Well, first of all, one of the things, clinically speaking, is that that's the normal physiological way we breathe. So when we start talking about patients who are on mechanical ventilators, most mechanical ventilators do not, well, I should say almost all of the mechanical ventilators do not work with negative pressure. It is not a normal physiological way that mechanical ventilators work. They work by increasing the pressure in in sort of the just kind of like pushing air into the lungs. So instead of it being this passive rush of air from higher to lower volume, it just forces the air. It just basically pushes it into the lungs. So it forces air into the lungs, creates a positive pressure breathing, which is the opposite of normal physiological way we breathe. And it's very damaging to the tissues of the lungs. It increases the intrathoracic pressure, which can impede blood flow through the lungs, and also impede vessels, which then obviously decreases cardiac output. So there's a lot of sort of a chain of bad events that occur with mechanical ventilation. So it's, especially when you're talking about ICU patients on long-term positive pressure sort of mechanical ventilation, we want to try to get people off of a mechanical ventilator as soon as possible because it is not the normal physiological way in which we normally breathe, and it's very damaging because we normally breathe under negative pressure breathing. Now, exhalation. Exhalation basically just increases the intrathoracic pressure through just normal elastic recoil of our lungs and chest. So the way I think of it is that, every action needs an equal and opposite reaction. That's exactly what happens with exhalation. You can only sort of expand that pressure or expand that volume in the lungs for so long. Eventually there has to be sort of a natural recoil, and that's what exhalation is. So exhalation is a very passive activity. Because it physiologically, as I have here on the screen, it physiologically just has to, right? You can't keep that chest sort of expanded during inhalation forever, right? There has to be a very sort of much recoil of that action. So if you want to think about it, and in terms of breathing, inhalation is the active activity. Exhalation is just the passive reaction to that. Does that make sense? Okay. So in terms of like the control of that, of the inhalation and the exhalation, you've got major muscles of inspiration obviously being your diaphragm. When the diaphragm contracts, it draws downward and allows for increased volume of the chest. You can also say that the external intercostals help with that as well. You also have some accessory muscles of inspiration, so like the sternocleidomastoid and the scalene muscles are sort of what we would call accessory muscles to inspiration. Should we normally see accessory muscle use when breathing? No. So if someone's using their accessory muscles to breathe, it looks like, you can really see their like sternocleidomastoid and their scalene muscles. That's not normal. Why would we see that? Why would we see accessory muscle use? Yeah. Exactly. And you're going to see it usually with an increased work of breathing. So if someone's short of breath, that's what you're going to kind of start to see. So you usually only see it when there's an increased work of breathing, in someone who's short of breath, in someone who's got some like diaphragmatic weakness, like, again, the neurologic patient with ALS who's got some weakness in their diaphragm, they're going to be using these accessory muscles to breathe. It's never a good sign to see someone using their accessory muscles. It means that their major muscles of inspiration are sort of pooping out. And we're really concerned about seeing, accessory muscle use. Yeah. Mm-hmm. Right, which we do not want to see. Yeah, not good, especially in the pediatric population. She said especially in the PICU, during RSV season with babies who have RSV, you see them using, those accessory muscles and the retractions. Not a good sign. Usually means that their respiratory muscles are pooping out. We're really concerned about them going into sort of respiratory distress and respiratory arrest. When would be a sort of normal, the only time that would be sort of a normal time to see accessory muscle use? Exercising, right, exactly. But again, you do not want to see someone lying in bed looking like they're breathing, looking like someone who's running, right? That's not normal. You don't want to see someone lying in a very relaxed state going, right? That's clearly not a normal physiological way to breathe. Good, very good. So that's sort of your major muscles of inspiration. And accessory muscles. Accessory muscles of expiration would be sort of like your abdominal and your sort of intercostal muscles. How come we don't have major muscles of expiration listed up here? There are none, right? I told you, it's a very passive activity. You don't need major muscle groups to exhale, right? You need major muscle groups to inhale, but you do not need major muscle groups to exhale. That's why you don't see any major muscles on the screen for that. Good. Again, because expiration is a very normal, relaxed, passive activity. No muscular effort is truly needed. Yeah.
So like in a coughing situation,
Mm-hmm.
is that not
It is. And I would say those would be those accessory muscles that you'd be using. Like the coughing, think about how your abdominal muscles contract when you cough. That's using those accessory muscles of expiration. Does that make sense? Good question. Okay. And I kind of have those pictures there for you in terms of the muscles that are used. Okay, the next factor, so number 2, the next factor of mechanics of breathing is that alveolar surface tension that we've already touched on, right? Again, the alveolar surface tension is sort of controlled by surfactant. and it occurs at any gas-liquid interface and really refers to the tendency for water molecules, liquid molecules, exposed to air to want to adhere to one another. So this is, again, where the function of surfactant comes into play. So let me give you an example, okay? Think about the way that liquid or water beads up when splashed like on a waterproof surface. So water gets on a raincoat or water gets on a pair of waterproof pants or something like that. What happens to those water molecules? Right? They bead up into pretty little beads. When that would happen on the inside of our alveolar sacs, as those sacs get smaller and that water beads, it's really hard to re-expand, right? So surfactant acts basically like a detergent. Think about when you have like a dish, a sink full of dirty dishes, right? And what happens when you put a couple of drops of dish detergent in that water? Right? That's exactly how surfactant acts inside the alveolar sacs. It just sort of allows for those water molecules to sort of let go of each other and allow for better, proper re-expansion of that sac after every breath, right? So surfactant basically acts as a detergent that lowers the surface tension by coating that air-liquid interface of the alveoli. Okay? So it decreases the surface tension and allows for better re-expansion of each one of those alveolar sacs. And again, that's why we're really concerned about babies less than 28 weeks gestation, because they don't make surfactant yet. And it makes re-expansion of those alveolar sacs extremely difficult. Yeah? Yes. You mean in terms of like for the preemies? Yeah. Yes, it can be very dangerous. Yeah. Right. So again, we don't want to see that. It's way more complicated than having normal cells in our lungs creating surfactant on their own. Very good. Thank you very much. Okay, so mechanics of breathing. 1, need proper inhalation and expiration. 2, need good alveolar decrease of surface tension by surfactant. 3, we need elastic properties of the lung and chest, right? And I've already talked about this elastic recoil, the tendency of the lungs to return to the resting state after inspiration. It's an equal and opposite reaction to inhalation, right? We need those lungs to be able to have elasticity to sort of recoil after every inspiration, right? Elastic recoil is normal. We want that. It's physiologic. Now, compliance of lung tissue. Compliance measure is the measure of lung and chest wall distensibility. So it's really defined as the volume change per unit of pressure change. So what I mean by that is the relative ease with which these structures of the lungs or the pulmonary system in general can be stretched. Okay? Now, think about that. Elastic recoil is good. Elastic recoil is just the opposite reaction, equal and opposite reaction of the inspiration. Would compliance be good? Again, compliance is the relative ease with which these structures can be stretched. Do we want our lungs to be super duper compliant? No, we don't. If our lungs were overly compliant, we would just fill up with air, fill up with air, fill up with air, fill up with air. And we'd all have these huge barrel chests because our lungs were over compliant and just allowing it to fill up, fill up, fill up, fill up, fill up, right? So over-compliance or increased compliance is not necessarily good. And decreased compliance is not necessarily good either. In fact, that they're so restricted that you can't allow for any gas to come in, right? So there really has to be this sweet spot in the middle in terms of compliance. But we don't really like compliance of the lung tissue near as much as we like elastic recoil of the lung tissue. Does that make sense? Okay. So too much or not enough compliance is bad. Okay, this slide just kind of illustrates this sort of normal mechanics of breathing that we've already talked about. Specifically looking at here B and C, right? In B, you have contraction of those respiratory muscles assisted sort of by, chest recoil. So the air sort of rushes in, the diaphragm contracts, it lowers. You get this big, inflated, increased volume inside the lung tissue. And what just has to happen? Airflow just comes rushing in, right? Now, that's inspiration. Now, at the end of inspiration here, you kind of start to see the muscle, the respiratory muscle contractions sort of maintaining that lung expansion. So you kind of continue to see lung expansion here. And it's now when the person starts to expirate that you see the lung recoil start to happen, starts coming back in, decreasing the volume in that lung. And what just has to happen passively? Airflow goes out. It just gets pushed out as that recoil occurs. So again, what I really want you to understand is B, C, and D in this slide. B is showing you the perfect example of negative pressure breathing. The volume increases, air just has to come in because it just wants to go to the lower volume. Okay? Okay. 4, airway resistance. Okay, this is kind of self-explanatory. Obviously, it's determined by the length, the radius, and the sort of the cross-sectional areas of the airway. So think about your airway, right? You've got your mouth, you've got your big trachea, you've got your the bronchi. Then as you get lower down into the lung fields, you have the bronchioles, you have the terminal bronchioles, and you have all your sort of alveolar sacs. As it goes down in that chain of structures, does resistance increase or decrease? What do you think? Increase, right? Because the structures are getting smaller, right? So you have to think about increased airway resistance as you get lower and lower down into those lung fields. Similar to the resistance of blood flow, right? As you get into those smaller vessels and into the capillaries, you've got increased resistance of blood flow. Same thing here happens in terms of gas. So there's very little resistance in the conducting airways. And you see increased resistance when you get to like the alveolar sacs and things like that, where you've got decreasing of the diameters. Obviously, the density, the viscosity, and the velocity of gas that's being brought into those airways also sort of impacts airway resistance. But again, it's usually determined by the length, the radius, and the cross-sectional area of those airways. And then last but not least, 5, the work of breathing. So work of breathing is determined by the muscular effort, and therefore the oxygen and energy sort of required for ventilation. We look at this clinically by something called PFTs, pulmonary function test. Anyone familiar with this or have seen any of them done in clinical? Okay. PFTs measure lung volumes and flow rates and can really be helpful in diagnosing lung diseases. So let's take a look at that. Lung volumes and capacities, okay? So looking at this screen means nothing to you, right? These words and these numbers. What's going to be more helpful is if you go to the next slide at this illustration and look at this illustration as I talk through some of these definitions and some of these volumes, okay? So the first one, tidal volume. Tidal volume, again, is like stroke volume in terms of the cardiovascular system. It is the volume of air moved during each normal breath. So again, sitting here at the table, sitting in your chair, you're seeing, hopefully, a normal tidal volume. Just the normal amount of volume that's moved in when you're sitting, breathing normally. So here in this illustration, it's just right here. You're just tidling along, breathing in, breathing out, breathing in, breathing out, not really thinking about it. Normal volume of air moved during that activity is about 500 milliliters, okay? So that's tidal volume. Think of tidal volume as just your normal breathing when you're not thinking about it, okay? That's the volume of air being moved. Then, you have a bigger capacity to breathe than just what you're doing sitting there in your chair, right? So then if I would ask you, okay, take the biggest, deepest breath in you can, right? That is what we would refer to as your inspiratory reserve volume. So it's your reserve of how much more you could actually breathe in above and beyond what you normally do sitting in your chair. Okay? That is your inspiratory reserve volume. And just like any other time when you inspire, you've got to equally expire, right? So then we're talking about your expiratory reserve volume. Okay? So here's your normal flow of breathing. I ask you to take a big deep breath in. It would look like this. And then you blow it out. So that normal volume, obviously, if you're just kind of breathing along like this, that normal volume is going to expand pretty much when I'm asking you to take a deep breath in and then blow it out. So a normal inspiratory reserve volume should be about 300 milliliters, and then your normal expiratory reserve volume is about 1,200, okay? What did I say? I said 300? Yes, 3,000. Ignore me. Look at the screen. Don't listen to me. All right. So now, you've done all you can do. You've tidaled. You've taken a big breath in. You've taken a big exhale out. There's a possibility that even after all of that, there might be a little bit of gas, a little bit of air left behind in your lungs. That is what we refer to as the residual volume. Okay? So the air that can't get out of the lungs, even after a big inspiratory and expiratory sort of phase. That's your residual volume. Now, there's a couple other definitions if you look back here at the screen. Vital capacity. What your vital capacity looks at or tests is your tidal volume, your inspiratory reserve volume, and your expiratory reserve volume all added together. That is what gives you the value of a vital capacity. And I used to do forced vital capacities, FVCs, all the time with my ALS patients, my neurologic patients, because of their diaphragmatic weakness. We used to test to see how well their respiratory effort is still sort of hanging in there, neurologically speaking. We used to do forced vital capacities on them all the time, where you do exactly that. You ask them to take a big deep breath in, and then there's like this little meter that you put in their mouth, and you ask them to blow out, and it measures basically all of that. It measures their tidal volume, their inspiratory reserve volume, and then their expiratory reserve volume, and that gives you their FVC, your forced vital capacity. So kind of just giving you a sort of a clinical picture to that. So that's what a vital capacity is. It's your tidal volume plus your inspiratory reserve volume plus your expiratory reserve volume. And that's what, you can sort of see that right here. It tells you right here with this arrow what the vital capacity is. It's all those things added together. Then the last sort of definition is the total lung capacity, and that's where you add all of this up. You add up the tidal volume and their inspiratory reserve volume and their expiratory reserve volume, just like you did for the vital capacity, but then add even to that the amount of volume left in their lungs, their residual volume, and that tells you someone's total lung capacity. It's very helpful in understanding someone's, respiratory capacities, so to speak, to see if there's any deficits, to see if there's any sort of weakness in those muscles. And again, like I said, I use that a lot with neurologic patients and looking at their ability to sort of, inhale and exhale properly. Any questions about that? Yes? No? Okay. All right. Last but not least, this discussion of gas transport. So we've talked about we just got done talking about the mechanics of ventilating, of getting the gas into and out of the lungs, right? But we know that ventilation is not the last end-all be-all, right? We need to get the gas in, but we also need to be able to perfuse, right? We need to be able to get that oxygenated blood out to the system, out to the tissues of the body. So gas transport occurs basically in 4 steps. Yes, you have to ventilate the lungs. But you also need diffusion of oxygen from that alveoli into the capillary blood like we've already talked about. You then need to be able to perfuse all of those systemic capillaries with oxygenated blood. So by systemic capillaries, I mean all the capillaries in all of our tissues in our whole body. And not only do you need to do that, but you need the diffusion of oxygen from those systemic capillaries actually into the cells, getting all that oxygenated sort of goodies from the capillaries actually into the tissues, right? Into the kidneys, into the liver, into the whatever. So that's the 4 steps of gas transport. Now, obviously, you also need the opposite of all of those steps to occur with the diffusion of CO2 to get that out of the tissues, into the blood, into the lungs, and then be expelled out, right? So the diffusion of CO2 basically occurs in the reverse order of this getting the oxygen into the tissues. So again, we talked about the mechanics, but none of it really matters if there isn't an actual exchange of goods, if there actually isn't an exchange of goods at that alveolar capillary connection. So, to say that sort of in a different way, if any step of this gas transport is impaired by either a respiratory or a cardiovascular disorder, gas exchange at that cellular level, at that alveolar capillary level, is compromised. And if you have any sort of compromise at that level, you're talking about what we talked about at the beginning of class, right? We're going to tie it all sort of nice and neat here with a bow at the end of class. If you've got any sort of problem with either the respiratory or the cardiovascular side of things, we're talking about a ventilation-perfusion mismatch. Ta-da. So a good ventilation-perfusion ratio, so V versus P, is necessary for good gas exchange. And normally we'd like to see ventilation, the ratio between ventilation and perfusion about 4 to 5, okay, in terms of a ratio, 0.8. You do not have to necessarily remember that, but I just want you to understand that we need a ratio between good ventilation and good perfusion. Now, that's under normal circumstances. That's if there's no mismatch, right? There's adequate ventilation and there's adequate perfusion. You're going to see a normal ratio of about 4 to 5. Now, there are certainly causes for abnormal ventilation or perfusion. Here's your causes. Something called dead space ventilation, shunt, or venous admixture. That means nothing to you. So let's make that mean something to you, right? Here's the first example. Dead space ventilation. And I'm going to sort of, is everyone good with this? Because I'm going to erase this here to draw some more. We're good with this? Okay. All right. Dead space ventilation is one example of a ventilation-perfusion mismatch. So if I'm going to draw you a picture, here's my alveolar sac. Here is my capillary running right up next to it, right? Again, I'm such a lovely artist. That's why I have to tell you what things are. Because you wouldn't have any idea if I didn't tell you. Okay, so with dead space ventilation, look here on the screen, you have ventilation, but no perfusion. So if I've got ventilation, what does that mean in terms of the oxygen getting into the alveolar sac? Is it happening? Yes. So oxygen's getting in. Ding, ding, ding. Wonderful. But there's no perfusion. So there's a ventilation-perfusion mismatch of 4 to nothing. Okay? Respiratory muscles are working. There's gas getting into the alveolar sac, but there is no exchange of oxygen occurring at this alveolar capillary membrane, right here between these thin walls that are supposed to diffuse gas, right? Why? Give me an example of why there would be, what would be a clinical reason for why there'd be great ventilation, great oxygen getting into the alveolar sacs, but no blood flow reaching to actually pick up that wonderful oxygen that's sitting right there ready to be diffused. Clot. Pulmonary embolism is the perfect PE. Pulmonary embolism is the perfect example of a dead space ventilation-perfusion mismatch. There is excellent ventilation. The oxygen is sitting right here in the alveolar sac, just waiting to come get picked up, and it gets stood up. No one comes, right? The blood does not come because of some big honking clot sitting right there, right? The blood gets caught right here, and there's no blood to come pick up that oxygen. That is a ventilation-perfusion mismatch, and that there's no perfusion. Ventilation's fine, but there's no perfusion. Let me ask you this. That being said, pathophysiologically, is oxygen therapy in this person going to help? No. You can oxygenate this alveolar as much as you want. If it's not getting picked up by blood, sorry, right? That's an example of dead space ventilation. It's a ventilation, perfect, no perfusion problem, okay? The next example I want to give you for a ventilation-perfusion mismatch is a shunt, okay? This is where there's perfusion, but no ventilation. So VP would be 0 to 5. So the heart's delivering blood. It's pumping blood really nicely to those alveolar sacs, to the lungs, but the blood is not passing a ventilated alveoli. Okay, so it looks like this. Let go. Thank you. Alveolar sac, capillary running by it, blood's flowing nicely. It comes here to this capillary alveolar membrane. Now it gets stood up. There's no oxygen in the alveoli to diffuse into the blood. So perfusion's great. Blood flow is great. Gas, not so great. There's no ventilation. I want you to focus not so much on this one right now, but I want you to focus on this one. The main reason for this is something called a capillary shunt, in which the blood is flowing through the capillaries surrounding an alveoli, but the alveoli is not getting ventilated. A perfect example of this would be like pneumonia, or a big mucus plug right here in the alveolar sac, where oxygen's here, it's trying to get in, but there's either a big mucus plug or there's a bunch of fluid, like with pneumonia, in the alveolar sac, and it's not allowing for adequate movement of oxygen down into the sac and therefore into the blood. So pneumonia, something called atelectasis, which is sort of the collapse of those alveolar sacs, either because of like a mucus plug or just hypoventilation. Sometimes you see atelectasis occur after surgery, and that's why it's just kind of a collapsed alveolar sac. That's why we harp on so much doing those incentive spirometries at the bedside, right? Sort of allow for proper opening of those alveolar sacs, because atelectasis, if you sort of have these collapsed alveoli, can certainly lead to a capillary shunt and therefore a perfusion, a ventilation perfusion mismatch. Really quickly, I'm just going to kind of mention it, but I think it's kind of confusing. Another example of a shunt is an anatomic shunt, where the blood moves from the right to the left side of the heart without actually going through the lungs. This would be like all those congenital heart defects that we talked about when we talked about that last semester. To me, that almost seems like dead space ventilation to me, because the blood is, the gas is getting into the lungs, but the blood's not there. But technically, per textbook, it's considered a shunt. And I guess the way you can sort of think about that is that it's almost as if the lungs don't exist. So therefore, there's like no ventilation to the lungs. Clinically speaking, I don't know. I find it sort of confusing. So I just wanted to mention it because technically it's considered a shunt and not a dead space ventilation. But the one I really want you to remember in terms of a shunt, a perfusion, but no ventilation problem is these examples down here. Pneumonia, atelectasis, and this picture that I have right here for you. Okay? Again, given the pathophysiology of this, would oxygen therapy help? No. You can give all the oxygen in the world that you want, but if there's a bunch of fluid in the alveolar sac, or there's a big mucus plug here blocking oxygen from getting in, you can give all the oxygen you want. It's not going to get into that alveolar sac. All right. Then last but not least is the venous admixture. It's not a true mismatch. If you want to think about it as anything, it's just sort of an inequity, where there's perfusion in excess of ventilation. So the ventilation isn't great, but it's not zero the way these other ones were. So basically what this one is that it results from a normal blood flow past poorly ventilated alveoli. Not completely wiped out, but poorly ventilated alveoli. So a really good example of that would be like hypoventilation, like in a patient, like a narcotic overdose sort of situation where they're just hypoventilating. So you're going to see, the blood leaves the lungs. There is this relationship of oxygen, getting into the alveolar sac and then getting into the blood, but the amount of oxygen present is just lower because of, opioid overdose or something like that. So that being said, would this mismatch respond to oxygen therapy? Yeah, because there's really structurally nothing wrong with this relationship. It's just that there's decreased oxygen coming in because someone's hypoventilating or there's some other sort of problem with them getting oxygen in. Good. Hope those make sense to you. And they are extremely clinically relevant. You will see them all the time, but you really do have to understand this. What I want you to totally get is this concept of ventilation perfusion mismatch and the definition of ventilation and the definition of perfusion. And I think you guys have that. So great. We will finish up with this content on Thursday and get into alterations.